Welcome to another episode of the Fast Track Cities podcast series. I am Dr. Jose Zuniga, and I'm the president of the International Association of Providers of AIDS Care, or IAPAC. This series of podcasts exists because IAPAC is dedicated to chronicling the history of the urban AIDS response. Our journey began with the darkest days of the global HIV epidemic in the early 1980s. It is winding its way through to today as cities fast-track their AIDS responses to end AIDS as a public health threat by 2030. Throughout this podcast series, we will hear from local heroes who've been on the front lines of the urban AIDS response. IAPAC is proud to tell this story. This episode offers a window into the science of HIV and why we believe that we have the tools at our disposal to end AIDS as a public health threat.
Welcome to the second episode of our Fast Track Cities podcast series, where we are focusing on how cities may well hold the key to our hopes for ending AIDS as a public health threat by 2030. In our first episode, we explored the early history of AIDS, the first reports of AIDS in 1981, and how HIV rapidly spread into the most serious public health threat of our time. We also previewed why we have the hope of radically reducing the number of new HIV infections and AIDS-related deaths globally, resulting from the momentous advances in HIV medicine. In this podcast episode, we are focusing more in depth on the science of HIV, how HIV attacks the body's immune system, how HIV acquisition can be prevented, how HIV infection can be effectively treated, and how treatment can prevent an HIV-positive individual from transmitting the virus. First, a bit about HIV itself. The human immunodeficiency virus infects key cells in the human immune system. It is transmitted in only a handful of ways: through sexual intercourse, during injecting drug use, from mother to child, and through the use of contaminated blood or blood products. Dr. Paula Monderi, Vice President and Chief Medical Officer of the International Association of Providers of AIDS Care, or IAPAC, describes the various means by which the virus is transmitted.
So although the HIV virus has infected roughly 36.7 million people worldwide over the last 4 decades, the virus is actually not easily transmissible. It cannot be transmitted through casual contact, shaking hands or hugging an infected person, or through saliva, as some infections that are passed on by fomites. So, certainly not through sharing like cooking utensils or dinnerware with an infected person. Most people who acquire, and it is not passed from person to person by blood-sucking insects, mosquitoes, for instance. This is one of the modes of transmission that in my part of the world people were concerned about in the early days of AIDS. Most people who acquire HIV do so during sexual intercourse. The most likely sexual behavior to result in HIV transmission is receptive anal intercourse with an HIV-infected partner, although globally more people acquire HIV during vaginal intercourse. So during sex involving a man and a woman, both can acquire HIV, although there are data to suggest that the risks are greatest for women. So in sub-Saharan Africa, for instance, where heterosexual intercourse is the primary mode of HIV transmission, women account for close to 60% of all the people living with HIV. And we believe this may be one of the reasons for this increased vulnerability of women, in addition to other social factors. HIV can also be transmitted through HIV-infected blood. There are several well-publicized cases of this. For instance, hemophiliac who received tainted blood or, blood that contained the HIV virus and therefore, became HIV-infected. In the early years of HIV/AIDS epidemic, many people became infected with HIV as a result of unsafe blood transfusions. Today, fortunately, this means of transmission is extremely rare because blood donations in most parts of the world are now routinely screened for the HIV virus. Another mode of transmission is the sharing of needles through injecting drug use, and this is a ready means of HIV transmission. In Eastern Europe, for example, the one region of the world where new HIV infections continue to rise, injecting drug use is the primary route of HIV transmission. HIV is also transmitted from mother to child, what we call vertical transmission, and this transmission occurs during pregnancy, directly through the bloodstream, during delivery, or during the period of breastfeeding.
HIV targets the human immune system, specifically cells that are known as CD4 cells. Dr. Mundari explains.
And the CD4 cell is a key actor in the body's immune system. This is why an important diagnostic tool for people living with HIV is taking the person's blood and measuring the number of CD4 cells in the blood, which we call the CD4 cell count. So people with normal immune systems typically have several hundred CD4 cells per milliliter of blood, but people with advanced HIV disease have much lower CD4 cell count.
Once a CD4 cell is infected with HIV, it eventually dies. Over time, as more and more of the immune system cells die, the body becomes increasingly vulnerable to various infections referred to as opportunistic. These include pneumocystis pneumonia and Kaposi sarcoma, a form of cancer previously concentrated among elderly Mediterranean men. Here we learn more from Dr. Mundari.
And the body becomes vulnerable to a range of opportunistic illnesses, called opportunistic illnesses because these are illnesses that are enabled by a weakened immune system. A similar thing happens when the body's immune system is depressed, say, by extreme chemotherapy and some cancer therapy. And some of the major opportunistic illnesses are infections such as tuberculosis, such as cryptococcal meningitis, which is an infection of the lining of the brain caused by a fungal-like organism called Cryptococcus. Pneumocystis pneumonia, which is one of the first bizarre pneumonias that actually led to the discovery of HIV. It's an unusual infecting organism to be occurring unless the immune system is severely suppressed. And also cancers, especially cancers that are associated with infectious organisms, such as non-Hodgkin's lymphoma, Kaposi sarcoma, and among women, cervical cancer. These are some of the major opportunistic illnesses that are likely to be seen once the immune system has been significantly incapacitated by HIV infection.
We can track the progression of HIV disease by measuring the number of CD4 cells present in a person's blood. By measuring the number of copies of the virus in the body, it is also possible today to assess the rate at which HIV is infecting additional cells. The greater the so-called viral load, or the number of HIV copies in the blood, the more rapidly HIV disease is progressing and the more transmissible the person is. The spread of HIV has varied around the world. Sexual intercourse is the primary way that HIV is transmitted in most of the world. In Latin America, North America, Western Europe, and parts of Asia, sex among men is the primary transmission route for HIV. In sub-Saharan Africa and parts of the Caribbean, heterosexual intercourse is responsible for the large majority of HIV infections. In countries in Eastern Europe and Central Asia, injecting drug use is the driving force of these still growing HIV epidemics. Although sexual transmission is playing an increasing role in the spread of HIV in that region. When viruses, bacteria, or other external substances enter the body, the immune system produces antibodies to fight them. This is the case when someone is newly infected with HIV, as the body produces a flood of antibodies in an attempt to ward off the infection. At first, these antibodies are seemingly able to control HIV, but eventually, the immune system's antibody response is unable to prevent the virus from spreading throughout the body. It typically requires about 10 years from initial infection for the severe symptoms of advanced HIV disease to manifest. Once again, IAPAC's Dr. Paula Mundari provides some important insights.
When someone is newly infected with HIV, the body produces a flood of antibodies in an attempt to ward off the infection. So the immune system does fight off HIV when it enters the body. At first, these antibodies are seemingly able to control HIV. Within days or weeks of infection, the viral load is apparently contained. But in the vast majority of cases, the body's natural defenses are overrun, as it were, and are not able to defeat HIV. So the body does not fail to produce antibodies to HIV, but What happens is some of the HIV infected cells, immune cells, and this is the process by which HIV evades the immune system. So some of the HIV infected cells, once they've been duped into multiplying and producing more HIV, will get destroyed in the process. But some of the HIV infected cells will survive this destruction. And the way they survive this destruction is by going into a resting or latent state. And in this resting state, the infected cells do not produce new HIV. Latently infected cells in the immune system contain HIV DNA deep within their nucleus. They hide deep inside tissues such as the lymph nodes and the gut, and in so doing, do not express any sign or show the body's immune system any sign that they are harboring HIV DNA. And this is how HIV evades the body's immune responses.
In the early days of the AIDS crisis, as the number of deaths steadily rose, the scientific world searched frantically for an effective way to treat HIV, or at least to prevent or manage HIV-related opportunistic infections. Early breakthroughs included the development of a series of ways to prevent pneumocystis pneumonia, one of the deadliest opportunistic infections that afflicted people with compromised immune systems. The isolation of HIV itself by laboratories in France and the United States in 1984 quickly led to the development of the first test to diagnose HIV infection. However, an HIV diagnosis translated into little more than a death sentence without a treatment option. In 1987, the U.S. Food and Drug Administration approved the first treatment for HIV. The antiretroviral drug AZT was not actually a new drug. It was originally developed in the 1960s to treat cancer, but subsequent testing revealed that it seemed to slow the HIV replication process. Dr. Julio Montaner, director of the British Columbia Centre of Excellence in HIV/AIDS in Vancouver, Canada, recalls the transition in his clinical setting from managing opportunistic infections to HIV treatment, starting with one antiretroviral drug.
We embarked on pneumocystis treatment studies, pneumocystis prevention studies, and all of that was going very well when really we like everybody else, realized that treating the opportunistic infections associated with HIV/AIDS was important but was not sufficient. There was an underlying immune deficiency that needed to be addressed. By that time, the virus had been discovered, and so the focus became, what can we do about it? So in '86, AZT became available. And given the prominence that our site had gained as a result of our pneumocystis work, and the fact that we were in the center of the epidemic in Canada, Vancouver was the worst affected city. And so very early on, we understood that there was a problem here, that a significant proportion of patients, increasingly over time, when exposed to AZT monotherapy, were developing resistance.
The approval of AZT was followed soon thereafter by the approval of an additional handful of drugs that clinicians began to test in unique combinations. Although these new drugs were welcomed in high-income countries by people living with HIV who were desperate for a lifeline, there were toxicities associated with the drugs, and their price tag was enormous. It soon became clear that the early drugs developed to treat HIV were far from a panacea. Dr. Paul Volberding of the University of California, San Francisco describes these early treatment advances.
So in the very early days, of course, we didn't even know about the virus. When the virus was identified in '83 and then '84, it really was amazing to me how fast we began to have treatments. AZT was first tested in 1985. Approved in 1987, and it was controversial. It didn't do very much. It was quite toxic, especially in the high doses that we used at first. But that was quickly followed by other drugs. And the concept of using multiple drugs at the same time is not new to HIV. It's what we do in cancer. It's what we do in tuberculosis. But as we began to have more drugs and use them together, they really started to have an effect. So even two drugs were better than one.
The true breakthrough in HIV medicine occurred at the 1996 International AIDS Conference in Vancouver, Canada. as years of investment by government research agencies and the pharmaceutical industry began to yield returns. Scientists started to develop novel new drugs that attacked additional stages of the HIV life cycle, but the traditional way of doing clinical trials for HIV drugs was lengthy and costly. Essentially, researchers gave experimental drugs to patients and waited, often for months or years, to observe clinical outcomes. A major diagnostic breakthrough, finding a way to measure the amount of virus in the blood, opened the door to a much swifter evaluation and approval of new antiretroviral drugs. By combining multiple antiretroviral drugs that target different phases of the HIV replication process, it proved possible to halt the disease process. Vancouver's Dr. Montaner explains.
After we showed that if people were adhering to the regimen, this was a very predictable outcome of the treatment, we felt that we were basically changing the trajectory of the disease from potential rapid progression to a slow progression. Now, all of these studies were phase 2b studies, so we didn't have really the definitive clinical evidence of efficacy, but confronted with the urgency of the situation in those days where AIDS-related deaths and HIV incidents were totally out of control, we felt that this was sufficient evidence for us to move forward, and really the rest is history.
Dr. Michael Sagg from the University of Alabama at Birmingham in the United States recounts the dramatic shift in the mid-1990s as new HIV treatments became available.
We were excited, and we were beginning to see this turn, this pivot. I liken the HIV epidemic very much to the Vietnam Memorial in Washington. And for those who have been there, you recall you start at one end in 1956 or 8 or so, and you slowly descend into this depths of hell, basically. Until before you know it, you're just overwhelmed, and this thing is just screaming at you with names and your own reflection staring back at you. And when you get about midway through it, you pivot and you start coming out of it. And to me, that was what 1996 was for all of us. The drugs started coming together in triple drug regimens that we used to call cocktails. And we could start to see the light at the other end, that there was hope and there was things that we could do to make a difference for folks and end the despair.
San Francisco's Dr. Volberding also recalls this paradigm shift.
We suddenly entered the era of transformative therapy, where a previously uniformly fatal disease suddenly was transformed, and people started not only to die more slowly, which had been the case, they actually started to recover. And there are still people alive who were near death when they started on the triple therapy, as we called it, in 1996. And, they're the lucky ones.
With the advent of highly active antiretroviral therapy in 1996, the inequities of our world became glaringly apparent. Other than Brazil, which courageously pledged in 1996 to provide combination antiretroviral therapy for free through its public health system, these life-saving therapies were accessible only in high-income countries. In 2000, at a time when tens of millions of people were living with HIV, less than 700,000 people worldwide were receiving HIV treatment, nearly all of them in high-income countries. In the countries where HIV treatment was available, the percentage of AIDS-related deaths declined rapidly by 2/3 or more. Dr. Susan Buchbinder, a clinician in San Francisco in the 1990s, and now clinical professor at the University of California, San Francisco, recalls the extraordinary effects of the new antiretroviral regimens.
We have this paper, the Bay Area Reporter, which is a gay-focused paper that is specific to San Francisco. And every week they would run pages and pages of obituaries. And there's this headline, "No obituaries this week." It was dramatic. It was like flipping a switch once we could get people onto really effective treatment.
But in the mid to late 1990s, the excitement that followed the Lazarus-like effect of antiretroviral therapy in the developed world dissipated as it became clear that in the developing countries, which accounted for 95% of the global epidemic, HIV treatment was unaffordable to all but the very wealthy. Globally, AIDS deaths still continue to increase year after year. The development of antiretroviral therapy, arguably the single greatest biomedical discovery since penicillin, had not altered the landscape of AIDS in the countries where the epidemic was having its most devastating effects. IAPAC President Dr. Jose Zuniga recalls both the excitement that fueled the early introduction of antiretroviral therapy in the developed world, but also the sobering realization of a world in which health inequities denied too many people the benefits of modern medicine.
The data that was released by Dr. Julio Montaner from Vancouver and others raised great hopes. It was a first treatment that really could improve the health status of people living with HIV for a significant length of time. And the possibility of living with HIV for a longer period of time than it had been imagined previously became a reality. But what also became a reality for us in our mental calculations regarding what this meant to the global AIDS response were the incredible investments that would need to be made in both human and financial resources that would be required in order for every man, woman, and child to benefit from highly active antiretroviral therapy. So we began asking ourselves questions about equity, including among political representatives of developing countries, about how we could accept treatments being unaffordable in developing countries where the majority of people living with HIV/AIDS lived. At the end of 1997, 2/3 of people living with HIV were in sub-Saharan Africa, and adding South and Central America and South and Southeast Asia to that calculations gave us 90% of the total number of persons living with HIV/AIDS on the globe. So that meant that 93% of people affected by HIV globally were living in developing world countries and had no access to antiretroviral therapy.
In the early years of the HIV treatment era, scientists, communities, and public health leaders in developing countries used a host of strategies to obtain access to these miracle drugs. Dr. Linda Gale Becker, Deputy Director of the Desmond Tutu HIV Center in Cape Town, South Africa, recalls how clinical trials became a lifeline for many people who could not otherwise afford the drugs.
And our initial approach was actually to engage pharmaceutical companies who wanted to run the very early antiretroviral trials. And of course, we saw this as an opportunity to introduce antiretrovirals to the country, but also get a bunch of people who otherwise would die onto these life-saving treatments. And so we had a fairly large cohort of people, young people in the most, whose lives were saved because they joined phase 2 and phase 3 antiretroviral drug trials. And as time went on, we were able to leverage more and more, I suppose, influence, in that we were also able to then ask for compassionate use at the end of the clinical trial. We could ensure that there was ongoing access for people. And we recently had a celebration of people who are still alive from those drug trials at that time. And, it's 25 years later. They almost certainly would have died. Their CD4s were incredibly low. We really used it as a way to literally save their lives.
Beginning in about 2000, the world's thinking about HIV treatment slowly began to change. Prodded primarily by AIDS activists, the HIV community embraced the right of all people living with HIV to obtain life-saving treatment. India's generics drug industry stepped forward to begin producing antiretroviral medicines that were much cheaper than those marketed in high-income countries. So began a process that would eventually reduce the cost of antiretroviral regimens by 99% in low- and middle-income countries. The Global Fund to Fight AIDS, Malaria, and Tuberculosis, as well as the U.S. President's Emergency Plan for AIDS Relief, or PEPFAR program, also stepped forward to finance the rapid introduction and scale-up of HIV treatment on a global scale, leveraging reduced commodity costs. Over time, brand name pharmaceutical companies began to issue voluntary licenses for their HIV medicines, enabling generic production and more affordable pricing for low and middle income countries. Dr. David Serwada, a professor at and director of the Makerere University's School of Public Health in Kampala, Uganda, helps place this transition into its proper context.
At that time, I remember my brother was actually infected with HIV, and we were really struggling with what to do. But it was a hope, but it was also discouraging because the treatment was extremely very expensive at the time. It was being costed that an annual treatment of triple therapy in 1996 was really estimated at $25,000 thereabout, including all the monitoring involved, which brought this hope completely out of reach of many African countries, let alone rural populations in Africa. So it was really despair that was palpable when one could see there was a hope. Of course, that has significantly changed since the emergency of PEPFAR, Presidential Emergency Initiative, which Bush announced, the U.S. Presidential Emergency Plan for AIDS Relief, PEPFAR, which was really unveiled in 2003, 2004. That was a real game changer.
As we learned in the first episode, these cumulative efforts far exceeded the most optimistic expectations. By the middle of 2017, the Joint United Nations Program on HIV/AIDS, or UNAIDS, estimated that nearly 21 million people worldwide were receiving HIV treatment. Only an extraordinary degree of cooperation could have produced such extraordinary results. Following Brazil's lead, the sub-Saharan African country of Botswana announced plans to roll out HIV treatment nationwide. Other countries quickly followed suit with similar commitments. International donors, primarily through PEPFAR and the Global Fund, not only invested in the purchase of antiretroviral drugs, but also in the infrastructure needed to deliver life-saving treatment to millions. National and local community organizations and other non-governmental organizations played pivotal roles in reaching communities where state-of-the-art medical care had never been available, and the U.S. National Institutes of Health, or NIH, and other public sector research agencies, along with the pharmaceutical industry, continued to invest in the development of continually improving HIV medicines. Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases at the U.S. National Institutes of Health, or NIH, speaks to the continued investment in HIV medicines.
Well, I think as most people know, the NIH is overwhelmingly the major funder of HIV/AIDS research by far. We spend approximately $3 billion a year, and for some time, the AIDS resources has been approximately 10% of the entire NIH budget. So if you look at all the things that have occurred, the development of drugs, the development of clinical trials to prove how to use the drugs, treatment as prevention, pre-exposure prophylaxis, all the vaccine development, all the cure initiatives, all of that is NIH funded. So the NIH is playing, I think no one would argue, the major role in trying to understand HIV and to try and develop countermeasures in both prevention and treatment.
Once antiretroviral therapy, or ART, was made available in developing countries, the same impact on AIDS deaths that had been witnessed earlier in developed countries became evident worldwide. Since global AIDS mortality peaked in 2005, the number of people dying of AIDS-related causes had been cut in half worldwide. Dr. Jose Zuniga from IAPAC speaks to this extraordinary achievement.
So many of us were really anxious to continue closing the gap in antiretroviral therapy uptake. For me, the ultimate way of evaluating the success of any campaign is to look at the outcomes. And if we look at campaigns to scale up access to antiretroviral therapy, we need to only look at, for example, the number of AIDS-related deaths worldwide. Globally, ART scale-up, or antiretroviral therapy scale-up, has been the primary contributor to an almost 48% decline in deaths from AIDS-related causes. That's from a peak of 1.9 million in 2005 to 1 million in 2016.
The earliest combination of HIV treatment regimens required individuals to take many drugs each day. Some of the pills had to be taken with food, others on an empty stomach, some needed to be refrigerated. Some of these medicines had awful side effects. When combination HIV treatment emerged, adhering to these regimens sometimes felt like a full-time job. Due to the steady improvements in HIV treatment regimens, the challenges that early HIV medications presented for people living with HIV have largely disappeared. Dr. Santiago Moreno, an infectious disease specialist in Madrid who has cared for people living with HIV since the early 1980s, has witnessed these profound changes in HIV treatment approaches.
Now the thing is completely different. Now we are with a disease which can be easily controlled with very, very, very good drugs. They are non-toxic, very well tolerated by the patient, highly effective, comfortable, convenient, one pill once daily, with no requirements. They can take in the morning, in the evening, with water, without water, with food, without food. So very, very easy to take. Which is, they can forget one pill one day and nothing will happen. So this is completely different. They are healthy, they are working, and their life expectancy is like ours. No limit in life expectancy.
But as it turns out, antiretroviral therapy does more than prevent people from living with HIV from becoming sick or dying. Scientific studies have confirmed that HIV treatment is perhaps the most potent tool we have to prevent HIV transmission. To a large degree, our understanding of the uses of HIV treatment for HIV prevention all began in Vancouver, Canada, where the rollout of antiretroviral therapy was associated with a steep decline in the number of new HIV infections. Here is Dr. Montaner from the British Columbia Center of Excellence in HIV/AIDS in Vancouver.
As we were rolling out the triple therapy regimens, starting in 1996, we were focused almost exclusively at the time in issues of morbidity, mortality, adherence, tolerability, safety, and so on and so forth. But because we were obsessively monitoring the epidemic at large, it became clear to me that as we roll out antiretroviral therapy, and people infected with HIV stop dying to the rate that they had been prior to 1996, the pool of people living with HIV in the community was actually getting larger. Of course, the next question was, what's happening with HIV incidence, the new infections? And interestingly, we saw that between 1996 and the year 2000, there was a significant drop in the number of new infections in the province of British Columbia, against the background of ever-growing sexually transmitted infections, particularly syphilis in our community, even in the same populations that were infected with HIV. We asked the question initially, could it be that treatment of those who are infected with HIV is contributing to decreasing infectiveness?
In 2008, the Swiss Federal Commission for HIV/AIDS issued a scientific statement that rocked the scientific world. After reviewing the medical literature, Swiss medical experts announced that HIV-positive persons who are receiving HIV treatment and have what is referred to as an undetectable viral load are unable to transmit the virus to their sexual partners. A person living with HIV is considered to have an undetectable viral load when HIV treatment has brought the level of virus in his or her body to such low levels that blood tests cannot detect the virus. The Swiss statement created enormous controversy, but subsequent scientific study would prove that these Swiss experts were 100% correct. In 2011, an international team of researchers reported results from a large multinational clinical trial known as HPTN-052. This study found that antiretroviral therapy reduced by at least 96% the risk of HIV transmission from HIV-positive to HIV-negative individuals. Subsequently, studies in a variety of settings in both developed and developing countries have found that the more people who are receiving HIV treatment, the fewer new HIV infections occur. Dr. Karl Diefenbach, director of the Division of AIDS at the NIH, describes the impact of these scientific findings.
So that is, to me, the beginning of the game changer. And in some ways, the entire PEPFAR program was in fact based on a promise that therapy could have a profound impact on the overall epidemic. It's not just enough to treat people, because if PEPFAR was all just about treatment, we wouldn't be seeing these effects. But because with good treatment, we have this secondary benefit on the level of prevention of transmission.
These results led to a major change in international HIV treatment guidelines. Before the HPTN 052 findings were reported, the World Health Organization was recommending that HIV treatment be started only after an individual's CD4 count had fallen below certain clinical thresholds. But the new findings led the WHO to recommend that all people living with HIV, regardless of their CD4 count, should receive HIV treatment, ensuring that more people living with HIV would benefit from antiretroviral therapy's therapeutic and preventative benefits. Again, Dr. Sirwada of the Makerere University School of Public Health in Uganda.
We slowly moved from treating under 250 CD4s, then moved up to 500 CD4, but now everybody should be tested and treated. I have already alluded to the surge strategy, the surge of HIV treatment and therefore prevention, whereby we are rationalizing the uses of funds by actually trying to make sure we figure out who are the population that have the highest risk, test them aggressively, and start them for HIV. That is now the current policy. And as I pointed out, the challenge or the tricky part is really trying to find out these populations.
Recognizing these benefits of HIV treatment, the world next embraced a set of ambitious targets to vastly expand the number of people living with HIV receiving treatment. Prompted by UNAIDS in 2014, countries around the world pledged that by 2020, 90% of all people living with HIV will know their HIV status, 90% of people with an HIV diagnosis will receive antiretroviral therapy, and 90% of people on antiretroviral therapy will achieve viral suppression or undetectable viral loads. These targets are known as the 90-90-90 targets. Dr. Tiefenbach from the NIH says the 90-90-90 targets have created great benefits, not just for people living with HIV, but also those seeking to avoid becoming infected.
So now we have proven that therapy, antiretroviral therapy, not only prevents transmission when you're durably suppressed, but you also should be taking therapy for your own health. So the combination of those two, the public health benefit as well as the health benefit to the individual, led us to this idea that really has sort of taken hold, and that becomes the root of 90-90-90.
Scientific developments are not only affecting HIV medical care. They have also had an enormous positive impact on the sexual, social, and psychological lives of people living with HIV. The overwhelming body of evidence on the prevention effectiveness of HIV treatment has also given rise to a global movement known as U equals U, or undetectable equals untransmittable. The NIH's Dr. Fauci explains why.
We know now, after the trials of treatment as prevention that showed extraordinary results in the decreasing the likelihood by well over 95% of individuals who are infected and brought their viral load to below detectable level, that they do not transmit infection to their partner. But beyond those studies, that have been cohort studies looking at individuals who over a long period of time have been essentially undetectable with no real partner-related transfer of infection. Namely, if you are with a partner who you know truly is undetectable, that is not a situation where you will see transmissible. And there's a lot of important social issues that go with that. I mean, people feeling more comfortable with themselves, that they're not looked upon with the stigma that they're dangerous to people.
Bruce Richmond, Executive Director of the Prevention Access Campaign, is one of the foremost advocates for U equals U. Its mission is the global promotion of the U equals U message, as both public health and human rights priorities.
U equals U plays a major role. I mean, it means that a person with HIV can have sex, conceive children without fear of transmission, just like people who don't have HIV. So in a sense, it normalizes the diagnosis. I mean, we're actually seeing U equals U used in places like New York City and Guatemala to reduce the stigma as part of their testing outreach programs. And we're also seeing U equals U is helping motivate people to stay on treatment and stay in care. And it's a really strong public health argument to ensure that all people with HIV have access to the treatment and the services, not only to keep them alive, but also to prevent new transmissions and get us closer to ending the epidemic.
Charles King, head of New York City's Housing Works, adds more about the importance of U equals U from the community perspective.
I think that U equals U has the ability to have a profound impact on the AIDS epidemic, and I think that is for three important reasons. First of all, I think it is a very good motivator for people to go on treatment. Appreciating that they can't transmit the virus is I think, really powerful in persuading people that now is the time to start, and it's also powerful in persuading people to stick with treatment. I think the second thing that U equals U has done is it has transformed the way so many people living with HIV think about themselves, feel about themselves. We talk about stigma all the time, but so much of stigma is self-imposed, our own sense of guilt, shame around having contracted the virus. So, the idea that as somebody living with HIV, I can be a sexually whole person and not live with that. And then lastly, ultimately, as we transform as people living with HIV, the way we see ourselves, that helps to inform the way other people around the world look at us.
The scientific news keeps getting better and better for HIV, even as more effective HIV treatments may be on the horizon. Research is currently being advanced, looking at further simplifying antiretroviral therapy. Instead of the current standard of HIV care, which involves taking a single pill every day that combines multiple drugs, much longer-acting antiretrovirals may soon be available. The NIH's Dr. Fauci welcomes these encouraging developments.
I think there's a great deal of excitement in the HIV research community. We just mentioned one of them when you talk about we already have early evidence of the potential importance of long-acting antivirals, also more potent drugs. I mean, right now, some of the newer integrase inhibitors have even a more powerful impact on the suppression of virus replication. Also, prevention options. As a community, as an HIV community, are very excited about prevention options. And that's the reason why we feel we have already tools that if we implemented them fully, we could really turn around the trajectory of the epidemic. And you're talking about things as simple as circumcision, which we know has a 60 to 65% chance of preventing acquisition of infection. Then you have treatment as prevention, which I just mentioned a moment ago. You have the efficacy of pre-exposure prophylaxis. As we know, when people adhere to the regimen, it's highly effective.
Work also continues toward a development of a cure for HIV. Dr. Fauci's colleague at the NIH, Dr. Diefenbach, describes the current state of cure research.
I'm optimistic that we will make significant progress toward a functional cure. Whether or not we can ever have a true sterilizing cure, the processes and what needs to go for that are fairly daunting, and we'll just have to wait and see. But I would say the sense all along is that within a significant subset of people, within the next 10 years or so, we will achieve some level of sustained virologic suppression in the absence of therapy is an achievable goal. How long that duration lasts, I think, is an interesting question, and that's what research is about.
Antiretroviral therapy for people living with HIV can not only prevent illness and death, it may well also be the key to controlling the HIV epidemic. However, the prevention benefit confirmed by the HPTN-052 trial focused on only one of the ways that antiretroviral drugs can prevent transmission. Over time, the scientific study has identified a variety of other ways that these drugs can help to prevent new HIV infections. The first preventative use of antiretroviral drugs occurred in the 1980s and early 1990s. Healthcare workers who were potentially exposed to HIV as a result of a needle stick or other injury while performing an invasive procedure were immediately provided with a 4-week regimen of antiretroviral drugs. The success of this so-called post-exposure prophylaxis, or PEP, in the healthcare setting eventually led to the approval of antiretroviral medicines for people exposed to HIV during sex or drug use. In the late 1990s, researchers found that providing antiretrovirals to HIV-positive pregnant women substantially reduced the risk of HIV transmission to newborns. This was a major scientific advance, given that as late as 2004, nearly 500,000 children were becoming infected with HIV every year. When antiretrovirals are not provided to an HIV-positive pregnant woman, the odds that her newborn will become infected with HIV are as high as 40 to 45%. But when antiretrovirals are given during pregnancy and when a woman is breastfeeding, the risks of transmission fall dramatically. Dr. Becker from Cape Town's Desmond Tutu Center on HIV explains.
The mother-to-child rate has plummeted and is now hovering between 1 and 2%, and some of the programs have even pushed it below 1%.
As a result of routine HIV testing and antiretroviral therapy in antenatal settings, HIV transmission from mother to child has been virtually eliminated in most high-income countries and in a growing number of developing countries. Globally, the number of children newly affected with HIV has fallen by 2/3 over the last 15 years. But there are still other ways that antiretroviral drugs aid in preventing new HIV infection among HIV-negative individuals. In recent years, a host of studies has found that taking antiretroviral medicines before having sex markedly reduces the risk of acquisition during sex. This regimen is called pre-exposure prophylaxis, more commonly known as PrEP. Dr. Sheena McCormick is a professor of clinical epidemiology at Imperial College London, who is involved in PrEP research.
So PrEP is the use of drugs that we use to treat HIV, to prevent HIV. And if we think about the story of PrEP, it started with a very good idea that perhaps giving these drugs to people who had just been exposed, I suppose, to HIV, post-exposure prophylaxis. We had PEP, and then the bright idea that you might give these before people were exposed so that the drugs had a chance to get into the cells, turn into their active state, and be ready for HIV when it arrived. And lo and behold, it's worked brilliantly in the clinical trials.
For people who take PrEP daily, the prevention effectiveness of antiretroviral regimen approaches 100%. To market this new prevention regimen, programs use new approaches to educate people at risk about ways they can avoid acquiring HIV. Dr. McCormick describes how it has worked in her city.
So we were certainly lucky in London that we already had, and UK generally, we already had a network of sexual health clinics that delivered care for people with HIV as well as prevention of STIs, including HIV and testing. So I think compared to many other countries, we were lucky to have that delivery option for PrEP. And whilst we were waiting for a public health decision about PrEP, we worked very closely with our community partners to promote the purchase of online PrEP, which is legal for 3 months prescription, and to support people to test safely around the PrEP that they were buying themselves. And that was a new departure for us. We've never been involved in that type of promotion before, but it worked absolutely brilliantly.
Where it has been made available, PrEP has also had other positive, sometimes surprising effects on our ability to fight AIDS. Here again is Dr. McCormick describing how PrEP is helping dissolve some of the stigma associated with HIV.
So one thing I've definitely seen in our setting is how PrEP has broken down that stigma between positive and negative populations, because they're both taking the same pill, both got the same interests in the side effects of the pills, the access and that sort of thing. And I think that's been a really magic thing. And if that could happen globally, because I still see stigma as being a really big global barrier to getting people to test in the first place.
Dr. Renslow Shearer, an HIV clinician in Chicago, relates the re-energizing nature of PrEP in relation to HIV prevention.
PrEP has re-energized, I think, the community in believing that we can end the epidemic, but it's also re-energized post-exposure prophylaxis, much more interest in what that is and how to access it, and it's energized treatment as prevention in providers, I think. It's caused, I think, a level of excitement in the community that we really haven't seen for the last few years up until this time.
To date, though, uptake of PrEP remains limited outside of a few major cities in high-income countries. Cost is a major barrier to broader access. Dr. Kenneth Mayer is a professor at the Harvard School of Public Health and medical research director at the Fenway Institute in Boston, which offers PrEP on demand.
The added cost of PrEP is a big barrier in many parts of the world. I was just recently in India, where the government has a certain budget to buy antiretrovirals for treatment, and they see PrEP as buying additional antiretrovirals for people who are not HIV infected. And their rationale is that if they have a finite amount of money, they'd rather spend the money on people who are infected and who may get sick if they don't get treated than preventing infection. Public health authorities very often see it as a zero-sum game. This is very short-sighted, we can all see, but in the near term, if you're a program administrator and you have a finite budget, this is how you make many of your decisions. So prevention gets short shrift in that kind of setting.
Although PrEP itself is highly effective, it works best in driving down rates of new infections when it's used along with other prevention approaches, including HIV treatment as prevention. Here again is Dr. Mayer.
PrEP is not an entity in and of itself, but what we currently are aware of is the fact that although the slope of the epidemic is going down, it's going down much too slowly. This is partially due, in fact, to the reality that almost half the people in the world living with HIV are not yet successfully on antiretroviral therapy and virologically suppressed, and doing this is going to be taking years. In the meantime, those individuals can still transmit HIV to others. The goals of programs like 90-90-90 are not going to be achieved if we just do business as usual. And PrEP can be an adjunct to scaling up treatment. It will keep a large number of people who might otherwise become HIV infected from becoming infected, so it stabilizes the number of new infections while the number of people who are already infected can be initiating therapy and become virologically suppressed.
Future episodes of our podcast series will examine how the combination of antiretroviral therapy and PrEP can have a powerful impact on our ability to reach zero new HIV infections and zero AIDS-related deaths. Indeed, several fast-track cities around the world now appear well on the way toward controlling their HIV epidemics through this powerful combination. Dr. Harold Jaffe, veteran of the U.S. Centers for Disease Control and Prevention, or CDC, HIV/AIDS efforts back in the early 1980s, believes this combination may hold the key to our hopes to end AIDS as a public health threat.
So given the tools we have right now, we have to really push testing, pre-exposure prophylaxis, and getting people infected into care with an undetectable viral load.
Dr. Chris Behrer, the Desmond Tutu Professor of Public Health and Human Rights at Johns Hopkins University in Baltimore, Maryland, concurs.
You know, I think what we're seeing is that where you have both high treatment coverage, where people are getting tested and getting treated, and you really are driving down the number of people living with HIV who are not on treatment, and you have high impact prevention like PrEP for the people who need it most, we really are
bending the curve. And we've had some intractable epidemics like gay men in the UK that have been going on for decades despite high treatment coverage. But that combination of treatment and PrEP, you can really now start to see.
Both for HIV treatment as prevention and for PrEP, testing is the essential gateway to getting at-risk HIV negative as well as HIV positive individuals into care. Dr. Becker describes how South Africa is approaching this challenge.
So currently, my model is that testing is the critical first step, and then people either go down one of two cascades, what I think of as the double helix. You either go down a prevention arm, which includes PrEP together with other combination prevention, or you go down the treatment arm if status is positive, and that should be on the same day if preferred. If not preferred, we absolutely recognize everybody has their choice and we can provide accordingly. So that's the model we are promulgating, particularly amongst young people, so that their impatience with the system, their not wanting to be fragmented and sent in all different directions, those needs are met. And so that is the model we certainly are trying to implement in every way. It doesn't stop there. It also then requires that people continue to be followed up all the way through to complete viral suppression and then finally to quality of life.
Yet, while there is more reason than ever before to know one's HIV status, it is estimated that 3 out of 10 people living with HIV worldwide still do not know their status. The CDC's Dr. Jaffe describes the challenge.
I think it's a complicated issue about why people aren't tested for HIV. Some people have no reason to think they're infected, and when they're tested and are very surprised, other people, I think, suspect they're infected but don't want to because they don't want to deal with it. So I think the main issue is trying to make the test more easily available. Home testing is an option, and have more positive reinforcement for testing, have physicians, community-based organizations, even websites encouraging people to be tested.
As you will hear in subsequent episodes of our podcast series, many fast-track cities are focusing much of their attention on reaching people who still do not know their HIV status. New testing methods such as Hiv Self Testing are being promoted, and innovative programs are beginning to include HIV tests as only one of many diagnostic tests they provide, offering people a value-added health proposition. The tools we have at our disposal now give us the means to bring the HIV epidemic under control. And there is even more reason for excitement and optimism, as these existing tools may soon be complemented by additional prevention tools. Here is Dr. Diffenbach from the NIH.
I'm very optimistic about where we are on the search for a safe, effective, and durable HIV vaccine. Currently, for the first time in the history of the global pandemic, we have 2 large proof of concept studies that are currently enrolling for HIV vaccines.
But there are also dark clouds on the horizon. Unlike the early years of AIDS, we do not lack the tools we need. For the future, the real question is whether we will have the political will to see the AIDS fight through to the end, which presents an extraordinary risk that can thwart our progress to date. Dr. Sharon Lewin, an Australian infectious disease specialist and professor of medicine at the University of Melbourne, describes the risk.
Because for us, and similar to many other cities, that's where our funding continues. And as we have successes, there's a real risk in a place like Australia that the government thinks this is no longer a big issue. But we all know with HIV that once you stop the investment, you run the risk of infections reoccurring and the problem resurfacing again.
San Francisco's Dr. Volberding shares Dr. Lewin's fears.
Well, it's good that we have good treatments, but the better they are, the more people can kind of forget the urgency of the early epidemic. And if we don't maintain pressure to continue to prevent HIV infection, it will increase again, I think inevitably.
IAPAC's Dr. Zuniga has similar concerns.
My fear, though, with respect to epidemic control is that we might take our foot off the accelerator. And by that I mean political will may wane, the resources that we need to have at our disposal may dry up. There may be a disease or two that crop up that take up the global public health space and allow us to take our eye off the ball at a time when we're making such significant progress across almost every country in attaining the 90-90-90 targets. So I worry about losing momentum that we've been building since the community embraced 90-90-90 in 2014.
For San Francisco's Dr. Buckbinder, the core elements that made the response to AIDS so successful to begin with will show us the way toward the future.
Well, I think activism is really what started us on this path towards addressing the epidemic, and I think it's activism that's going to take us over the finish line. So my greatest hope is really in people working together. And when I say activists, again, I mean from communities that are affected by HIV, but everybody who's working in the HIV field. So my greatest hope is that we really learn from each other and that we come together as a community to try to solve this problem, because it's not going to be solvable if we're trying to do this in separate silos.
Later in our podcast series, we will examine how cities around the world are fast-tracking their AIDS responses to ensure that no one is left behind in the face of great optimism spurred by scientific advancements. Most of the world's people live in urban areas, as do most of the world's people living with HIV. If we hope to seize this historic opportunity to end AIDS as a public health threat by 2030, we will need the intelligence, ingenuity, energy, and passion of our fast-track cities to help take us across the finish line. In our next episode, we will look at how the Fast Track Cities initiative is supporting cities to accelerate their local AIDS responses.
Stigma against people living with HIV is unacceptable, especially when it's experienced at a health facility. Know your rights. There are groups of people living with HIV that can educate you about your rights, including the Global Network of People Living with HIV. Visit www.gnpplus.net for more information. Also, if you feel that your rights are being violated, report your concerns to your health facility's administrator, or consider switching to a different health facility. Your local health department can assist with locating health facilities near where you live.